Hi, my name is Teresa Coleman. I'm an RN, CCRN in the ICU. I would like to welcome you to my program on high-risk, low-volume education for ICU nurses. You can click on the spacebar to advance through this slide presentation. The overview of this program is to develop your knowledge related to 4 therapies that have been identified as high-risk, low-volume therapies that you might see as critical care nurses in your area. These are the objectives I would like to cover for high risk, low volume. Hopefully by the end of this, you'll be able to identify 4 therapies. You will be able to identify the importance of each and the key terms related to each one. I want you to be able to see some specific cultural needs related to these therapies. And we're going to also investigate a few ethical issues related to a few of them. And we're going to discuss your nursing role and maintaining your level of competence with these therapies. The goal of this is to increase your confidence level in taking care of these 4 therapies that are considered high risk, low volume. And it'll be through this educational program that is being presented to you. So as we go through this, just click on the spacebar or your enter key and we will get started right now. Let us begin. We will begin by looking at external ventricular drain placement and management first. The overview for this is to develop your knowledge related to external ventricular drain insertion and management in the ICU. We're going to first go over some simple anatomy related to your EVD placement. We're going to explain and demonstrate hopefully what an EVD system looks like and is. We're going to relate why the EVD system is considered the gold standard for treatment and when and where in our facility will an EVD be placed. And we're going to examine your role for assisting with this procedure. So my goal for you is to increase your confidence level whenever you have an EVD that's going to be placed or you have to manage it in the critical care unit. On this slide, we're just going to look at basic simple anatomy. So you can tell by the picture that this is of our head. So we have a skull and that will house our brain. Okay. All this is called our cranial vault. And there's 3 layers to our cranial vault. We have a scalp and it's highly vascular, so it's going to bleed. We have the skull and it's thick. It's a thick outer shell and it's meant to protect our soft brain. So our skull is thickest in the frontal and the occipital areas. And our physician's going to come in towards the right, which we'll discuss in a little bit. There's 3 layers to our meninges, which is the final. You got the dura mater, the arachnoid, and the pia mater. And we got to get through all 3 of these layers to get down there into where the CSF is in the ventricles for us to drain. We have approximately 135 to 150 mLs total at one time of CSF fluid contained in our ventricles and throughout our brain tissue areas here, like the arachnoid space. So we can make up to 500 to 600 mLs a day. Usually this fluid should be clear and colorless, and it's made up of 99% water. This slide demonstrates the Monroe-Kelly hypothesis theory. This is about how the skull has only limited capacity for each of these 3 areas listed. We have the blood that makes up 10%, the brain that makes up 80%, and the CSF fluid that makes up the other 10%. And you can see the first picture is normal. This is normal ICP. So our normal ICP is 0 to 15 millimeters of mercury. Now notice, remember earlier, the last slide, well, coming up in another slide, you're going to end up seeing the millimeters of mercury and centimeters of mercury. For this slide, we are saying that the normal range is 0 to 15 millimeters of mercury at the lateral ventricles for ICP measurement. And the brain can accommodate for small adjustments and keep the ICP within normal range. So you can see here in the second area that there's compensated ICP remaining normal. So you have the brain, you have the CSF, you've got the venous blood, and then the arterial blood, and then you have this purple area that's a mass. So something has given up a little bit of its space to accommodate that mass. So the ICP there is still normal. Well, you can quickly shift. If the mass gets bigger, you can see in that last picture that you now have an ICP that's elevated and it's uncompensated, and something's going to give because this mass is getting bigger and bigger. So the only thing that's going to end up being able to give is through the base of the skull. The brain is going to potentially herniate and lead to the patient dying. So now we want to think about, okay, what is this EVD? What is it? Why do I even need this? So this is a device that is actually placed by a neurosurgeon. It is a ventricular ostomy, and it'll actually be a creation of a hole. And the goal of the surgeon is to actually access the lateral ventricles where the CSF fluid is. And he'll use a catheter, and this catheter is hollow. And he's going to tunnel this in. He's going to use a drill. He's going to drill in through the outer shell that we just talked about, and then he's going to go through sensitive areas, and then he's going to get like a flashback, and he's going to then pull out his stylet, and we're going to connect it to our pressure cable to throw our number up on the monitor to be able to know what our ICP is. And the purpose of this drain is to drain out CSF, and the whole idea is through gravity and through a rising ICP, and our physician gives us orders on how high he wants this to be for us to drain fluid, and we'll see that in just a couple more minutes. The function of the drain is to relieve the ICP, to monitor the ICP. Is it rising? Do we need to drain out some infected CSF fluid? Is there bloody CSF fluid? Sometimes they want it used after surgery to drain out leftover, like edema. There may be edema from the surgery. I've had physicians that have used this device, and actually it's not even used to monitor the ICP. It's used after the craniotomy. They have a bone flap, and you really don't get an accurate ICP because you have release there's no bone there on the skull, and they're just using it to drain out excess fluid that could be accumulating in the skull, in the head. And then other times for a hemorrhage, they'll place it for that as well. This device is still considered the gold standard for ICP monitoring, although there's not a lot of research about it. It is still the gold standard. So now you're probably wondering, where is this going to happen? Well, here at our facility, we can actually do them in the emergency room. We can do them in the neuro-interventional biplane suite. Of course, they can be done in an operating room, but they can also be done right here in the intensive care unit at the bedside. Back in the day, it used to be only in the operating room, but that has changed. We are now able to do it right here. So now that we know what it is and where it can happen, you're probably wondering, well, when will it happen? How much time have I got? Well, it can happen now, and it can happen emergently. So what is your role for this procedure? Number one, you're going to assist your physician with the placement of this device. You're going to have to let your charge nurse know so you can gather all your resources. Your charge nurse has to know what's happening in the unit. You need to make sure you don't forget to get a consent. Make sure you get somebody, delegate that task, get somebody to print out a consent for you. You need to go gather your equipment. And here at North Florida, we have a neuro cart, an emergency cart that has everything in it that you need. So go grab that. You're going to need to make sure you got a sign for your pole. You need to make sure you have a sign for the door because this is a sterile procedure. And you want a pole in the bedroom, in the at the bedside, so you can put your sign on there for your warning, don't adjust the head of the bed. And you need to make sure you have your universal timeout ready to go. And just in case you've got some extra supplies know where your extra supplies are in the clean utility room if you don't have something in that cart. So this is an example of what the equipment will look like in one of the boxes that you open that you'll need. This was a picture taken by our own Grayson Audia, who helped develop this program here at North Florida. And you can see the drill that's up there. That is actually a hand cranked drill. So this is some of the stuff you'd look at and some things you want to consider as well. We don't necessarily have a protocol here for give sedation or antibiotics or anything, so make sure that you talk to your physician about, does he want you to give any sedation, does he want any medication at all for blood pressure management, are there any antibiotics? There are some catheters that have got antibiotics in them, but we are not currently using those here, but they are an option. And you want to make sure you got your cable ready to go, your pressure cable for your monitor, and have it labeled for ICP as well. Make sure you got your exam light on overhead so your physician can see well. Be mindful of clinical alerts for your area. Like anything, you need to make sure you have all your stuff ready to go. You want to verify that there is an order for this, that you got the right patient. You want to make sure that you got a consent. Obviously, if there's an emergency, sometimes this is done without a family member or the patient signing, but make sure that you address that consent issue. Make sure you provide patient education. What are your two patient identifiers? What should you be looking at? What if your patient can't communicate with you verbally? Be aware of that. Make sure there's hand hygiene. You wash your hands. Everybody in the room washes their hands when you're touching this patient. This is considered sterile technique, so you need to open all of your packages in a sterile fashion and maintain your strict sterile technique. Always do a universal timeout. This is an invasive procedure and you need to do a universal timeout. And the whole idea here is to provide maximal barrier sterile technique. This is what helps us to still do this at the bedside in the ICU and out of the OR. There's been research that's done that says if you maintain maximum sterile barrier technique, then you are not at risk for an infection. Very important for everybody to do that, and make sure that you also have handoff communication with every nurse when it comes to an EVD being present. There needs to be exact orders of what your physician is going to want. You want to be as prepared as you can before your physician actually arrives at the bedside if you've got time. You want to make sure you've gone ahead and you open up your packages sterilely. You may need 2 people to do this. So you got to have sterile gloves on, maintain sterile technique, open, flush prepare your device, make sure your physician is okay with you preparing the tubing in line. Don't just do that. Make sure that's what they want you to do, because they want to make sure that that is primed correctly and that there's no air in there and that it's done with a sterile preservative-free saline. So you can get all that ready, and then you want to make sure you got everything that is open to air dead-ended with a red sterile cap. And anytime you touch this device after that with a red sterile cap, it is sterilely done with sterile gloves, opening, changing it out, anything. We have no standard protocol here at North Florida right now, but we are considering protocol recommendations. So you need to be aware of what the standard is and what's evidence-based. And this standard here was researched by the AANN, and we are going to try to go forward with doing something like this. So this is just a recommendation, but you can see there that you have your EVD catheter insertion recommendations. We clip hair, we don't shave. Your skin preps that are recommended, minimize the number of people that are in the room. They recommend using a antibiotic-coated catheter. We do not use that here. And they recommend having an EVD insertion checklist, which we have not done yet. EVD dressing changes. We need to be aware that of what type of dressing it is, the frequency of the dressing change, and the personnel that are approved to actually do that. You need to be specially trained in that. Nobody can just go up and do an EVD dressing change. And obviously, if you see one coming off, you need to secure it. Let your physician know that is happening as well. There is evidence that says to use a bio-occlusive dressing with a biopatch. That is recommendation evidence-based practice, and that biopatch, we'll see a slide later of where that actually will go. You have EVD maintenance and cerebral fluid sampling. Again, nobody can just go in there and pull a sample off of an EVD. You need to be specially trained in that. There's only certain locations that can be sampled, and it is a very much a aseptic technique in doing that. You always want to, anytime you're touching this device, maintain sterility. Also, education and surveillance. We need to be doing continued checkoffs and competencies related to this device, and there'll be more to come here at North Florida on that one. And you want to always make sure that we're doing infection control rounds, looking at that device, making sure that things are appropriate, dressings intact, how long has it been in place, is the bag being emptied like it's supposed to. Okay, so your doctor is now here. What are you going to do? You've got everything set up and ready to go. You want to limit the number of people that are in the room, and that's number one. Make sure you got your sign up on the door. Your head of the bed's going to be up 45 degrees. He's going to actually come in he's going to find his landmark, which is called Coker's Point, and he's going to most likely come in towards the right side, the right frontal cerebral hemisphere, because this, according to research, shows that 90% of people, it's the non-dominant side for language. So that's why your physician's going in on that side, okay? He's not just, anticipating or picking something like that. He's going in there on purpose to avoid causing damage to the brain. He's going to use a local anesthetic and then he's going to make an incision into the brain. And he's going to end up doing a burr hole in there, and it's going to be that little twist drill, and it's going to go in there, and you're going to hear it making funny noises. And then he's going to use a scalpel, and he's going to pierce the dura mater and the pia mater. And you may actually hear a pop with that as well. He's going to end up priming his catheter, and he's going to actually insert that no more than about 7 centimeters. He's going to look for some CF flow to come back, and then he's going to remove his stylet, and he may ask for an opening intracranial pressure, or he'll tell you what that opening intracranial pressure is. You need to write that down and record that. And then what he's going to do is he's going to actually tunnel that catheter away from the original insertion site. And evidence is 3 to 5 centimeters away from the insertion site. That's going to actually be your exit site that you're going to actually see. And some people sometimes they'll be sutured, sometimes they may be stapled, but most of the time here at North Florida, we do sutures. And then we're going to actually connect it to the EVD system, and he's going to address the site for us. Now you want to make sure that when he's setting the EVD, he's going to tell you, okay, I want you to put it at 20. Well, if you look there on the green side where it's centimeters of H2O and the other side that is millimeters of mercury, you can tell a big difference. So 20 is way down for centimeters of H2O, and 20 on millimeters of mercury is really high. So you need to make sure that you confirm with your physician, sir, which one are we measuring by? Millimeters of mercury, which is the blue, or centimeters of water, which is the green. Here at North Florida, our physicians prefer the green one, the centimeters of water, but always clarify, because we did end up with a second physician that wanted the other side. So make sure you are for sure on what that order is. This is a slide looking at ICP waveform. So you can see here that we have a compliant brain in pink, and we got a nice little pretty P1, P2, and P3. And then we have a non-compliant brain in the green, P1, P2, P3, and in this picture, the P2 is high. So our P1 is related to, it's called our percussion wave, and it relates to the arterial pulsation when it first comes in. P2 is our tidal wave, which it represents our intracranial compliance, and then P3 is our dicrotic wave, which is our venous pulsation. So kind of like, you're thinking kind of like a line almost, but it's ICP and definitely a little different. So in this particular picture, an easy thing to do, if you see a P2 that is elevated, it means most likely there is some intracranial hypertension going on. So you want to figure out what's going on. Do I need to go up on my nicardipine that's infusing right now? Do I have a blood pressure medication that I need to do? What's happening that's causing that intracranial pressure to go up, and get that fixed. Also check your catheters and check all the way down your tubing. Is there something blocking the tubing? Is there like a little piece of something that's in there? Do not flush that. That is a physician's role to do, but you would need to troubleshoot this and figure out what is going on. This is just an example of what an EVD site looks like. These are the recommendations. And it's actually a really good slide. Evidence-based practice shows that this is what we should be doing. And if you look right there in the middle, you can see that on this particular EVD, it's stapled. It's not necessary. What says right there, note sutures are not a component of proposed practice change. So it's not like there's something wrong because those are stapled. It's physician preference. And you can see where the biopatch is 3 to 5 centimeters away from where he actually tunneled in to insert his EVD. So what are some management things that you need to consider? So remember, you're always teaching. Whenever you're going into the bedside, there's family there, the patient's there, you're always assessing the site, and you're talking about the EVD. Always teach. You want to always make sure that your sign is present, warning people that you have an EVD in use and that the head of the bed is at the ordered angle. It is usually never ordered to go anything less than 30 degrees, and the reason for this is because it promotes the venous return out of the head, so the ICP can continue to stay lower. You want to even consider locking that head of the bed so nobody will accidentally hit it, or a family member lean up against it, or even we've had issues where lab has come in. This is another reason why it's so important to have a sign at the head of the bed somewhere in there to say, hey, don't mess with this. This is a very important thing. You always want to make sure that the head is midline, and this helps to not obstruct the venous return as well. Always verify the order. Every time you're taking over somebody's EVD or it's your first patient, no matter what, always verify that your order is correct with where the height is on that EVD system. This is very important. If you have a high chamber, the amount of CSF is going to be reduced. That's draining. If you have a low chamber, then it's going to increase it. Always maintain the sterility of the system. So you should be zeroing this system every 12 hours to atmospheric air, and anytime that you're repositioning the patient. And here at North Florida, we zero at the tragus. So always make sure that you know from your physician where he's wanting you to zero as well, because there have been physicians that may consider something else, but you want to make sure that you know. And always change those red caps and put on a brand new sterile red cap each time. So the standard is you should be inspecting those sites at least a minimum of 4 hours. I would recommend, if you have got a new EVD and you're in there every hour assessing that ICP and you're assessing the drainage coming out, look at your site. Go ahead and make sure that there's nothing going on there. You want to be looking for any type of drainage. Have we got a CSF leak that's going on? Is there any redness or swelling? And you want to notify that physician immediately if there's any problems. More considerations for EVD management. You want to make sure that anytime you're going to be leaving the unit, that EVD system is clamped. Now, when I say clamped, you don't want to clamp this for more than an hour. And if your ICP is high, is clamping the EVD an actual good idea to go down for, say, an MRI? What if you have an MRI and you know your patient's going to be laying flat for 2 hours to get this procedure done, and their ICP has been elevated and their blood pressure has been high? Is that a good idea to take my patient down? So call your physician, let them know what is going on. Don't just say, well, you know you can clamp this thing up to an hour, without really critically thinking through what your patient is experiencing before you take them down for a procedure. But you can clamp them up to an hour if your doctor is okay with that. Always clamp the system as soon as you're transporting. Don't leave it open, draining, clamp it, because anything can happen in transport. And then remember when you come back to unclamp the system. Make sure you've zeroed everything and you unclamp it and you got everything going the way it needs to go again. Assess them neurologically. What is their status? How frequent are vital signs ordered? Check your orders and make sure that you are doing what you are supposed to be doing. You want to be monitoring for signs and symptoms of increased intracranial pressure. Some of these symptoms can be your patient's complaining of a headache. All of a sudden you realize their heart rate is lower than what it normally is. They're getting bradycardic. They could be becoming more lethargic. They can actually complain of nausea and vomit as well. So if you see these symptoms, troubleshoot your system and see if there's something going on that you may have missed. Did you forget to unclamp something? Hourly, you want to assess for drainage. You want to make a note of how much is it? Is your physician got anything clamped or unclamped? Is he looking for you to clamp for an hour, then open it again and see how much drainage comes out? Make sure you check for kinks in your tubing. Is there any leaks at all? Is your dressing dry and tack? You also want to take care in how you provide your care. Things that we do can actually increase our patient's ICP. And I've seen that done with your suctioning a patient or your orally cleaning their mouth, or you turn and position them. So just be aware that what you do could significantly increase their ICP. Some things to consider for documentation. You want to, here at North Florida, we use Meditech, and you want to make sure that you add the intervention frequent neurochecks, because this is going to have everything in it. And you will be able to document a lot in just one area. It'll be easily findable. Make sure you record your ICP, your CPP. Your CPP is your map minus your ICP. So even if your system's isn't figuring that one out, you can figure it out. You can validate your results, but make sure if you do what we call here VRing, which is pulling your vital signs into the system, that you get rid of the false ICP readings. You do not, if you have your thing clamped, it's not going to pull in the right data, and you want to make sure you pull the right data into the system. Record what your drain level is at and which one is the measurement. Is it by the millimeters of mercury or the centimeters of water? You look at the quantity and color of the fluid and what's your dressing site. Potential complications with having an EVD system in place can include, obviously, skin infections. You can end up with ventriculitis. You can end up with meningitis, subdural empyema, osteomyelitis. You can have sepsis, endocarditis, intracranial or intra-abdominal abscesses, and you can have chronic headaches. So this is why it's very important to make sure we do not give our patients an infection while they have this device. So let me read this note here to the side. It says excessive CSF drainage can result in decompression of cranial contents and damage bridging cortical veins, leading to hematoma formation or rupture. So can you remember back in one of the previous slides when I talked about how many mLs are actually in a ventricle? It's like 135 to 150. So if you drop this EVD down, and all of a sudden, like you're gone to lunch and it falls. Let's say you didn't secure it on the pole and it falls, and you come back and you've got 150 cc's in that when you had 0 when you walked away. What most likely could have happened? Basically you're going to collapse those ventricles and potentially cause a herniation. So we need to be extremely cautious to make sure that these are secured the right way on the poles, that we make sure the patient is as safe as possible, because you can't just replace 135 to 150 cc's. That's a very serious complication for a patient. So some other signs and symptoms that you need to be thinking about too is the whole Cushing triad. You want to catch a patient before they start going bad. So things that you want to be considering when you have an EVD in place is what is going on with my patient? Are my pupils equal? Is one bigger than the other? Are they sluggish? Are they even reacting to light anymore? What's my patient's level of consciousness? Are they growing more lethargic? Do I have a rising systolic pressure and a decreasing diastolic? This would be called a widening pulse pressure. Partnered with the bradycardia and slow irregular respirations. This is not a good sign, and this means your patient is potentially herniating. And this could also be another sign is decerebrate posturing. This is a late sign too of brain herniation. Important things to consider is patient stroke education. So if we have this device in, most likely they have had some type of a stroke or something's happened that we're going to have to educate them. At North Florida, we are a comprehensive stroke center. So DNV GL is our credentialing agency. So we want to make sure that we print out a packet. This is actually a 51-page packet, and we need to make sure our patients get it. There's going to be all kinds of information in there, and you can encourage the patient to write down information that they gather during their time while they're in the hospital. They can ask questions of the physician and just keep it all in one place. And you want to be continually revisiting that and seeing if they have any questions and see if we can answer them. Part of the standard of care for these patients, you want to make sure you have a plan of care, goals in the hospital. These need to include nutrition. What is their nutrition goals while they are here as well? Are we addressing nutrition? This is a big thing for DNV. What type of lifestyle changes do they need to make? What are our discharge plans? Where are they going to go? Is case management involved? What are our risk factors that we want to avoid? What are some signs and symptoms of stroke and cardiovascular events that we need to tell our patients to be looking for when they are discharged? If they're smoking, we need to be encouraging them to stop. If they're overweight, let's encourage them to reduce that weight. If they're not overweight, we need to encourage them to stay in a normal weight. What about diabetes? Are they diabetic at all? We need to have blood sugar control. Are they hypertensive? We need to make sure they got good blood pressure control as well. Are they monitoring their lipid levels? What kind of labs need to be done? We need to also be looking for abnormal heart rhythms like AFib. Are we on medication to control that? And are they going to actually be compliant with all their medications? How can we make that happen? Do we need to have case management involved so we can figure out if there's a financial issue with medications? Part of continuing to take care of these is to provide for your own professional enrichment. So how can you stay competent with taking care of an EVD? Well, you can talk to your educational people and see what types of things they've got offered. Here at North Florida, we use EBSCO, which is in place of Lippincott through our health stream, and we have a dynamic health role that you can look through information on your iMobile and educate yourself as well. We can look at doing some case studies. You can actually review charts through our PACE system, PACE program here. You can review your own charts and others' charts and look for compliance with core measures. We can help develop checklists. We can do observations, peer reviews, post-tests, self-assessments, hopefully simulations as we go forward, as our education department continues to grow. Some certifications that you can look for neuro, American Association of Neuroscience Nurses, or the AANN. You can join this organization and receive wonderful information on all of neuroscience, and a certification you can look for is an SCRN, which is our stroke certification RN, and a CNRN certification, which is like a certified neuro RN. And you can go to that website and look into those further. The other certification you can get to stay current is the American Association of Critical Care Nurses, AACN, and they use the Synergy model for patient care, and you can receive your certified critical care registered nurse certification from there, CCRN. And there's also research that shows high validity simulations correlate to better outcomes. So the more you practice this stuff and we can put you in scenarios, the better you're going to get at it. We are now going to look at the bispectral index monitor. This is to provide an overview to develop your knowledge related to the use of the bispectral index monitoring system. Our objectives for this will be to define what a BIS is. We're going to refer to it as a BIS. We're going to discuss some of the pathophysiology for BIS monitoring. We're going to look at how do we determine a patient would benefit from a BIS monitoring. What exactly is your role as a nurse? We'll look at the values of what the BIS numbers mean, and we're going to explain and demonstrate the use of the BIS. My goal for you is to increase your confidence level when you have to use the BIS on a patient that you're taking care of in the critical care unit. What is a bispectral index monitor, BIS? So this is going to be a device that actually does the same job as one of those big EEG monitors. Little, obviously less intense than one of those sitting in your patient's room with all those wires hooked up. So it's a simpler version of that. And it's going to be actually a more objective tool. So when we use our RAS scale to look at a patient's sedation level for pain or sedation, period, it's subjective. So we as a nurse, if our nurse is not responding, we look for subjective things to see whether or not they're in pain. And we'll titrate our medications based on that. When we actually have the BIS monitor on, we're actually, this is very objective. We look at this number and we can say, okay, this is what this number means and this is what I should do. This is also very simple and it's non-invasive. You do not need a consent for this, and you will not need a doctor present to do this either. You'll need his order, which we'll discuss in a minute. So why use a BIS monitoring system? If your physician orders what we call a neuromuscular blockade, for example, Nimbex, Roconium, Vecuronium, they need to be on a BIS monitor. They are going to be paralyzed. They could potentially have a brain injury. They could be on a hypothermia protocol for post-cardiac arrest. They could be acute respiratory distress syndrome, or they could even be end-of-life care. In one of these articles referenced here on the slide, they were actually talking about how you can better get a patient's pain under control when you can't really tell subjectively by putting a BIS on them to kind of titrate those medications to an effective dose. You can also have your patient on a BIS monitor for any type of procedural nursing, say bedside tracheostomy that they're doing, or they're doing a cardioversion. Or you have your patient on a lot of pain medication and sedation and they're ventilated. You can actually use it on them as well. And there's actually research that shows that nursing confidence actually goes up when their patient is able to be treated appropriately to make sure that they are actually sedated enough. What does a BIS do? Well, it actually used to only be used in an OR for a very long time. And the reason why is because it could measure the depth of anesthesia that was being used. For us, we are looking at the same thing. How much sedation, how bad, what is my patient's brainwave activities doing right now? Is my patient undersedated or are they oversedated? So we're going to take a look at what that 0 to 100 actually means in just a little bit on another slide. But for now, you just know 100 is awake and 0 is everything is suppressed and there's no brain activity at all. These things can be used as a good clinical indicator to trend for survival post-hypothermia, protocols for post-resuscitative care. And research has shown that the higher that BIS value is, the better the neurological outcome is for the patient. So that's a good indicator to use a BIS as well because it shows evidence. The other thing is it also helps us to treat a patient that is paralyzed effectively for pain and their sedation level. Just because they're paralyzed does not mean that they're pain-free, nor are they asleep. They imagine being paralyzed and not being able to communicate with anybody. They've actually had patients that report post-traumatic stress disorder from being paralyzed during procedures and not having their pain adequately treated. So how does a BIS work? These sensors that we put across the patient's forehead actually will capture and the EEG tracings. And that little blue box that you saw, that blue box job is to digitally convert those signals into a number. And that box has to be really close to the patient's head in order to do that. Okay, and it's a really complicated formula, and it converts it and it throws that number up there on the screen for us. But the one thing you should realize is that there's a 10 to 30 second delay in what the patient is actually doing and that number we see on the monitor. There's a lag because of that complicated conversion that has to take place. So some of the key terms that you need to know for BIS and that you can actually look on your monitor for is the suppression ratio, SR value. Sometimes you may have to record this for your physician. And this is a percentage value showing how much of the EEG over the last 63 seconds was suppressed. Okay, it's an average number. And a high number would mean there's a lot of suppression. Okay, that could be a bad thing. And the other thing here is the electromyograph, so the EMG. And this indicates that there's actually some muscle activity or a high frequency interference. So there could be something near the patient. Is there a phone near it? Is there, is there something that's messing up the signal conversion? So look to troubleshoot that one. And then you actually have the signal quality index, SQI, and this will actually measures the signal to the channel source. So that is usually in like a solid green on our monitors at North Florida. What is the nurse's role? Well, your role is going to be to collaborate with your doctors, your nurse practitioner, or your PA to set up goals for therapy. So here at North Florida, we've seen, on the MAR for fentanyl and Versed, it'll say titrate to a BIS value of 40 to 60. So you're going to need to know which end is the bad end to be on, which end is the good end to be on, where should I keep my patient in the middle, and effectively titrate those drugs. So you also want to assess the therapy goals daily for your patients, because if you end up having a patient on a neural blockade for greater than 48 hours, it actually can be an indicator that they're going to do poorly. So we want to try and get them off before a 48-hour time frame. You want to provide teaching to the patient and the family prior to starting. There's going to be some anxiety with the family when they see their loved one that may have been moving before to not moving at all. So we want to make sure we keep them informed on what's going on. And before you start, you want to go ahead and assess their level of consciousness. What is their current sedation level? What is their current pain level? What does my skin look like that I'm going to be putting the sensors on? And what is their current neurological assessment? Because you're going to suppress them. You're not going to get a true neurological assessment once they are paralyzed. You're not going to be able just to wake them up. So now you're ready to do the procedure. You do not have to have consent. You do not have to have a physician ready to go in with you. He doesn't have to be there at all, he or she. You get to do this on your own, and it's very simple to set up. So you're going to go gather your equipment. You want to make sure you prep the skin on the forehead with alcohol prep, just to get that nice and all the oil off the skin so that your sensors are going to stick really good. And on your sensors, there's going to be circles, 1, 2, 3, and 4, and they will clearly tell you where to put these on your patient's head. And once you get these sensors on the head, you want to push down on each sensor for about 5 seconds, because this is just going to make sure that they're good and connected and you've got good contact. Because remember, this has got to go through the skin, like through the brain, through the skin, through the cable, and be converted into a number. So we want good contact. You're going to end up taking the end of that little tab thing, you're going to slip it into your cable box, set that cable box near your patient's head, and then you're going to plug it into the cable monitor. So now you've got your number up on your monitor. What does that BIS value mean? How do I interpret that? Well, here on the top of this pyramid, you can see that 100 to 80, this is our most alert state. So 100, you're going to be awake, alert, they're responding appropriately, they're talking to you, hopefully, unless they're really sick, then they may be having seizures or lots of activity going on. And then the 80 is going to be okay. They can respond to a loud verbal or mild probing. Okay, so they're falling asleep a little bit, but you can get them up. You can still get them awake. Then they're going to go down into the moderate sedation range. This is going to be a BIS value of 80 to 60. If they're at 80, they're going to be able to respond to that loud verbal or mild probing. And then as they get closer to 60, they're going to end up being unresponsive to verbal stimuli. Okay, they're going to require a lot of probing, a lot of probing to wake up. Now, the next one after that is going to be right there to the side, 60 to 40. This is considered general anesthesia. This is what general anesthesia wants. And this is the numbers that we're seeing at North Florida on our MAR for titrating our BIS value. Okay, so if they're at 60, they're unresponsive to verbal stimuli. And then they're going to end up, as they get closer to 40, they're going to be unresponsive to verbal and less responsive to that physical stimuli, okay? They may not respond to pain as much, all right? They're going to be less and less responsive to deep stimuli. And then the next one under this that we want to stay out of is our 40 to 20. This is deep sedation, drug-induced coma. They are unresponsive to verbal and less responsive to physical stimuli to minimally responsiveness, okay? There's hardly any function going on at all when they get down to 20. And then the very last one is the 20 to 0, which is showing very minimal brain function to no brain function and maybe a little bit of spinal reflexes. We don't want our patients anywhere near that when we are giving them paralytics or any medications. You might be wondering what can affect my BIS values, okay? So if you all of a sudden have a higher BIS value, you need to look to see, is there some type of nauseous stimuli going on? Are you deep suctioning the patient? Are you doing mouth care? I actually had my patient BIS go off the chart when I started doing mouth care. That really agitated the patient. Weaning of sedation or neuroblockade. This could be a good thing. We want to see them wake up. So if we see a higher BIS value, that's okay in that situation. We're trying to get them off of that stuff. They could also be in REM sleep. Remember, this is a more alert part of sleep. They can still go through their sleep cycles when they're paralyzed. What about seizure activity? Is my patient having new seizure activity going on? That is always a possibility. Are they shivering? That can happen when they're on the hypothermia protocol. They could be shivering and their BIS value is going up because of that. There can actually be environmental stimuli that noise could be increasing their arousal state and making them more alert to their surroundings. So you may want to consider, how many people are in the room during this. And do they need to maybe come in groups of, 2 or 3 and maybe, be a little bit quieter if they come in? You may have to address that issue. And also lower BIS values. What can create lower ones? Well, you may have them on too much sedation. They could be getting too much or too much neuroblockade and you need to wean that back. They can also be on the hypothermia protocol as well, and now they're in an induced, really deep type of cold state. They can also be in a deep sleep, and they can also have complications, like there could be decreased brain perfusion from hemodynamic instability. This could be a problem that needs to be assessed. They could also have a worsening neurological condition that has developed as well. Key points that you should consider for nursing, okay? You want to make sure that you record your BIS value when you start therapy, hourly, and with any of your medication titrations. You want to look for any type of secondary parameters that your physician may ask for. This could be like blood pressure. Are you titrating, Levophed? Is there anything else that they may want you to be monitoring while you're doing the BIS? Also looking at the skin condition of where those sensors are located. Okay, is it irritating the head? Are they on correctly? Good contact. You want to also be watching for sudden increases or decreases in your BIS value and troubleshoot those when they happen. You also want to look at your SR value. Is there an increase in your SR? Remember, this is your suppression ratio. This could be an indicator that there's some type of brain injury going on. Is there a cerebral injury? Have we got hemodynamic instability? Is there actually cerebral ischemia going on? Are we given too high doses of medication? Okay, you need to look at that number. And also, feel confident when you're using the BIS monitoring to treat your pain that your patient could be having, or the sedation level effectively. They're on a neuroblockade. They can't communicate with you, and they're totally dependent on you being able to treat them effectively so that they don't have post-traumatic stress disorder after being paralyzed, and they remember not being able to communicate with people. So let the BIS monitoring system just increase your confidence to be able to do what you need to do to take care of your patient better, okay? We're going to look at the use of the CORTRAK system with the placement of small bore feeding tubes. An overview of this presentation is to just develop your knowledge that's related to the CORTRAK system for small bore feeding tube placements that you may have to place here in the critical care unit. The objectives for this presentation, we're going to just describe some simple anatomy for consideration with using this system, and we're going to recognize why the CORTRAK system is used for the placement of these feeding tubes. We want to examine your role as the nurse in using the system, and we want to discuss maintaining your competence with using the CORTRAK system as well. The goal will be to increase your confidence when using the CORTRAK system for a small bore tube feeding placement. So let's look at our anatomy for this tube feeding placement. So obviously we're going to be going in through the nares, and we're going to advance this tube along the base of the nasal cavity, okay? And we're going to hopefully enter, we're going to enter the oral pharynx and then hopefully the esophagus, okay? This is where potentially a problem can occur where it actually goes down into the lung. So if we've correctly entered the esophagus, we're going to end up passing through there and through the sphincter into the stomach. And then the insertion can continue to go down past the pyloric sphincter, well, into the pylorus, through the pyloric sphincter, and into the duodenum, okay? And you can see off there, so you've got the mouth here on the right where you're going down the throat, and then you've got this front picture here of where you have your trachea and your lungs and the esophagus running behind that. And you got a picture up here to the right that shows the curvature there of the stomach and the anatomy here. And you can see how to actually go post-pyloric, it's actually going to take a little bit of work to get there. So this system requires a lot of patience to be able to get there, and part of the system is going to being able to identify when you actually have a C curvature and then you have another C and a drop with your anatomy to identify correct placement. What is CORTRAK? So CORTRAK, we use CORTRAK 2. This is just simply, it's manufactured by CORPAK Med Systems. Halyard Health actually has acquired the system. It is an US FDA administration, so FDA approved device to use for feeding. It's for enteral access, and it's to feed your patient. It actually uses an electromagnetic signal, and it goes this stylet, the tip of the stylet actually will transmit up through to the receiver on the patient's chest, and it lets us know where it is in their GI tract. And it's going to confirm feeding tube tip placement is optimal versus placed in the lung. So this is actually making nurses feel more confident that their tubes are actually in the correct place when they are trained properly on this system. Why use it? Why bother using a CORTRAK system at all? I've been in nursing for a very long time, and we used to place these things blindly all the time. But we also did this blindly, and a lot of them went in the lungs. And a lot of nurses became very uncomfortable with inserting these. And all of a sudden, I don't know, maybe 7 years ago, 6, 7 years ago, there was a huge pushback where nursing was not going to be putting these in anymore. And at our facility, they had to be put in under fluoro, which meant they went to an interventional radiology department to have those placed, and those people weren't very happy about having to place them either. So this device has actually been a wonderful thing to use, because now if we're adequately trained, we can decrease the amount of x-rays that we have to use to validate placement. So we're going to decrease our radiation exposure to our patients. And there's less chance of developing pneumothorax or tube feeds being delivered into the lungs like they were with blind insertions. And also sometimes there's long delays in putting in tubes because they're just extremely difficult to put in. So now we have an extended period of time where our patient is not receiving the nutrition that they desperately need. What is your role with using the CoreTrack? Well, you need to follow your facility's policies and procedures first and foremost. So always look those up and be aware of what they are. You want to make sure that you know your upper respiratory and your lower gastrointestinal anatomy, okay? So you can figure out what exactly it is that you're seeing on this monitor. Make sure that your patient and your family are informed that this is a temporary nature for a tube feed route. Okay, this complies with the patient's advance directive because there are people who will say, well, you know, Dad didn't want a feeding tube. He said that he never wanted that placed. So we have to reassure our family members and our patients this is just temporary. This is not a long-term solution. Sometimes this is just to get through, you know, a few weeks of needing some nutrition without having to necessarily address having a more permanent type of procedure done that's invasive, like a gastrostomy tube or a GJ tube. So provide them with education on it and reassure them that it does go by their advanced directive wishes. Also, you need to be aware of what are some absolute contraindications. If your patient has had a basilar skull fracture or some type of facial injury, it is a contraindication for sure. Do not place this device or use this to place a tube feeding. That needs to be done in a very special situation. And here's some other things that are also listed. Like if your patient has some bleeding issues or anything where their INR is really high, you don't want to start inserting something with a guide wire in it, which is what this device has. It essentially has a guide wire in it. And then if they have esophageal varices or they have if they've got a gastric bypass or something's going on with the anatomy and you know it, you do not want to place this device and you need to let your physician know that. This is where you become a patient advocate to say, okay, my patient has some dangerous situations here and this is not safe to place. How do I use CoreTrack? Again, follow your facility's recommendations, and these recommendations will most likely include correct positioning of your patient. They need to be on their back, supine, head of the bed no less than 30 to 45 degrees, okay? And receiver placement is key. This is where the FDA says that this is where problems will develop. This receiver has got to be on, per the manufacturer's description in their literature, the xyphosternal junction. So right there you can see the red arrow. That is where the very tip of the receiver goes. And you can see that in the other slide that says what is CoreTrack. There's like a receiver there. And you're going to place it right on that little area there. And you're going to want to make sure that the device is kept level and that it's midline and it's parallel with the spine, okay? Because even just a little bit of movement, you're going to throw your tracings off. So there's a little weight thing that you can put over the receiver to help hold it in place, or you may need to get a friend. If your patient is moving a lot or their anatomy is a little different, you need to get a friend to hold your receiver in place so it does not shift during the insertion. So you're going to end up now measuring from the tip of the nose to the ear and then down to the stomach. And if you're needing to go post-caloric, you need to add another 10 to 15 centimeters past that mark. You want to then insert the orange tab into the cable that's connected to the monitor, okay? And you're going to want to lubricate the tip of the tube, and this is going to activate the lubricant that is on it, okay? You can dip it in water first and then lubricate it, and then that also helps with insertion into the nair, all right? So when you insert into the nair, you want to keep going back slowly until you meet the posterior pharynx, and this is an estimated 10 centimeters, okay? Now you're going to hit your activation on your receiver. You can hit, there's a little orange button on there, you can hit that, or somebody, your friend who's come to help you hold the receiver can hit it, or on the screen, you can hit that to activate, and it's going to start to energize that receiver. And you're going to begin to advance it, and you're going to ask your patient to swallow to aid the advancement of the tube. And you're going to have to watch your tracings. So as the tube begins to progress, watch your monitor. You're going to see an anterior view on the main part of the screen, and to the left you can see a cross-sectional view. And this is going to help with the view of the proximal jejunum, okay? And when you actually get in there, you're going to see a drop in that depth. There's also an additional view that you can see, which is called a lateral view, all right? So as you're moving this tube in, you want to go slow, and you want to monitor them for any coughing or respiratory distress. And there are times where they may not have hardly any gag at all, and they won't cough or anything. And you're going to need to monitor that, the curvature and what you're seeing on your screen, and making sure that that placement is right, because sometimes you're going to be curled up in the lung, and this patient has not responded at all, and it is in the lung. All right, so very important to pay attention to placement of that device for sure, the receiver on the chest. Okay, so monitor the tracing. If there's a sharp turn to the right, which is usually where it's going to go first, normally you're going to end up having, if you go into a lung, it's going to go right first, and then you can end up having a left placement. All right, so if that does happen and you see a sharp curvature to the right or left, just slowly pull out your tube, just back it off a little bit, about 15 centimeters, and then this will begin the new tracing all over again. There's no need to restart the monitor. Just slowly begin to go forward again. So once you've identified that you've got it in place, you want to make sure that you secure the tube, okay, and press end on the monitor. And the stylet that is in there is actually good to be used for another time, okay? So you want to keep that stylet, and you can put it in the clean bag that's in the kit. You can actually use it again if there's any question about placement, so you can reinsert that stylet and retrace again and re-advance the tube again. You want to look at your tracings, and you should be able to print them out and put them in the chart. And if your facility still requires you to get a KUB to validate that the placement is correct, you need to make sure that is ordered. And at North Florida, we're still using that double check system. We still get a KUB to verify that the tube is in the correct spot. And then you want to document that you actually inserted it and what views you use to validate placement. So here you can see this first view is anterior view, and you can see the nice, it's going down straight down the middle, and then you have this curvature as soon as it, it hits right above this line here, the R and L axis, and it curves, and then you have some other curvatures. It's going back up, and so you can kind of see there where it's at. And then you have this depth cross section, which is next, and that shows the nice little drop that it had from it's going down, and then you drop in the duodenum and you're going over. And then the last view is the lateral view. It kind of gives you an angle of where everything is from that view as well. So here's a few little tidbits on how far you can anticipate your tube going down. What are the potential complications that can still occur with CORTRAC? You would think that if we have this device, there would be no complications. Well, there are. So there were 54 adverse events that were reported to MAUDE, the MAUDE database, between January 2006 and February 2016. So that's a 10-year period. Of these 54 events, 98% were still placed in the lung, 37% in the left lung, 40% in the right lung. So you can see there the right lung is usually the higher one, and 15% was unknown placement. Of these 98%, 21% ended up with pneumothoraxes, and 21% ended up with pneumonitis as reported complications. Of these 98%, 17% of these placements resulted in the patient's death. So when this was investigated a little bit further, they identified that 89% of the tracings reviewed revealed that the operator failed to recognize correct placement. Okay, so they failed to see that they were actually in the wrong place 89% of the time of these 54 events. So after that, the FDA actually issued a warning, a safety warning to the surgery and critical care medicine in January 12th of 2018, saying, okay, now from January 2012 to January 2017, which is a 5-year period, we now have 51 medical device reports, and they were pneumothorax occurrences. So there's more concern here. So although they did not determine if it was directly related to the device, 11 deaths occurred of these 51 reports. So you can see, even with the use of CORTRAC, there is still potential complications. So there are some recommendations that we will see here in a minute. So this leads me to nursing competence. How do we make sure that you're competent as a nurse to use the CORTRAC and actually place the Dopphoff? Well, this study here, you can look up this reference by Acquire et al. And just released this year in the AACN journal, that basically practice helps with competence, okay? With novice CORTRAC super users, there was a low confidence in them feeling like they could adequately place the tube correctly until they had successfully completed 8 to 10 tube feeding placements. The FDA actually recommends that only clinical staff with prerequisite training developed by the manufacturer and credentialed by their institution should even place these. These should not just be placed by just anybody, okay? And you can tell that even with a novice CORTRAC super user, now they're the super user, they're identified in the facility as a super user, that they still feel like it took 8 to 10 placements on average to begin to increase their confidence with using it. Okay, so currently there are no standard ways to measure competence for nurses. The manufacturer has a skill checklist of 27 items. The United Kingdom has an 8-category checklist with 31 items total. And there was only one organization that has reported so far that they use a written test. All right, so there's no standardization for anything for maintaining competence with this. And you can see it's a pretty lengthy procedure, and most likely it's because it can have serious complications if a person is not trained correctly. So the important thing here too is just focusing on the skill of placing one of these does not necessarily demonstrate competence. There needs to be some critical judgment that is also involved. Like I said, with does my patient have esophageal varices? Should I even be using this device? If my device slips, just putting it in place, is that enough? Am I truly watching my tracings and identifying them correctly? So some of these have been more because they didn't do a follow-up KUB. So until we see for sure that we have placed enough where we are statistically placing them correctly on the first time, we may still see KUBs ordered here at North Florida. So what are the recent recommendations for maintaining nursing competence for this skill with using a CORTRAC and a small bore tube placement? There was recently a prospective observational study that was done in Central Florida, January of 2017 through March 2017. And they brought some nurses in and they took a look at, how they performed the skill. So out of that, and these were super users that they looked at, out of that study, they ended up saying, okay, this is going to be a high risk, complex, low frequency skill for nurses using this device. They recommended that there is rigorous didactic, which is a 2-hour minimum, which is going to be your verbal, like learning, not hands-on. Okay, this is the actual learning to a lecture, listening to a lecture, along with a psychomotor skills training. Okay, so 2 hours plus psychomotor. They also recommend that they identify there's not just one approach that is best for everybody, but use a combination of the AACN recommendations, the manuals, your institutional protocols, the operator guides. Use a combination of these to check competence. They also recommend validating that nurses know all 3 view uses: the anterior, depth, cross-section, and the lateral. Here at North Florida, we're pretty good at looking at the anterior and the depth. I don't think we utilize the lateral as much, and that's something we need to probably reconsider and take a look at. They also recommend having a second person validate. If you're unsure of the placement and you had a hard time putting it in, you need to maybe go get your other super user and validate a tracing to make sure it's in the correct place. And then, of course, consider your radiographic confirmations. We still do that at North Florida, and that's going to be the standard for a little bit. And also do not auscultate. This is not something that's going to be effective with these small bores. That does not confirm placements of these devices. They also recommend modifying this lengthy manufacturer's checklist to just the essential components because it's so lengthy it's going to create a problem. We need to figure out how to get that shortened up a little bit. And that initial competency, that when you're checking off a super user, they need to do at least 3 successful placements first before you let them loose. 3 successful placements for initial competency. They also want competency to include clinical judgment. Okay. And then the interval of competency reassessment with planned remedial instruction needs to be developed. So when you get reassessed on this, if there's any errors, you go ahead and you have an immediate instruction time on how to fix that error. I don't have it listed on the slide, but they actually also recommended, in order to maintain competence of a super user, that they should be placing on average two placements per week. That's the minimum to maintain competence after your initial validation. We will now go over the Rapid Infuser Level 1. So an overview of this presentation is going to be to develop your knowledge with use of the Rapid Infuser Level 1 for a massive transfusion protocol that you would perform as a critical care nurse. The objectives for this presentation is that we will define what a rapid infuser is. We're going to discuss the indications for its use, identify the goals of therapy, and we're going to discuss potential complications associated with the use of the therapy, and then we're going to examine your role in the use and demonstrate competency, knowledge maintaining competency. My goal for you will be to increase your confidence level related to the use of a rapid infuser for your patient. So what is a rapid infuser level 1? You can see right here in the picture, this is a picture of ours, and I actually have the tubing in it so you can kind of see what that looks like. It basically is a device that can rapidly infuse fluids or blood products into the vascular space if it's been depleted. So it also has the capability of warming the fluids, and this will prevent hypothermia with rapid infusions of blood. It does require specialized tubing, and it's tubing that can actually withstand the bend and the pressure and the warming. It's really like it's a good solid tubing. The flow rate on these are 75 to 30,000 mLs an hour. So that can be pretty fast. You can go slow and really fast. It's like you let this thing run and it's not connected to a patient. It's like a little hose squirting out at the end. The pressure that can be maintained by those pressure devices where you hang the fluid is 300 millimeters of mercury. So why would I even use a rapid infuser? If your patient, well, we've actually got them in the unit. If your patient is an OB patient and they just hemorrhaged in the OR, sometimes the charge nurse actually gets called there to help with this. They end up having to help with setting the machine up and getting the patient transfused quickly. And then sometimes that patient is transferred over to the ICU and you may have to continue the therapy. Okay, so you could have an obstetrical hemorrhage, any type of trauma involving blood loss. You can have an acute variceal hemorrhage, which we have seen a few times. Those are pretty traumatic when they occur. You can have an uncontrolled hemorrhage of any sort. So basically, an uncontrolled hemorrhage is going to be something that considers requiring 3 units of blood in an hour, or 5 units of blood over a 3 to 4 hour period, or 10 units in a 24-hour period. Also, sometimes these patients hypothermia induction after cardiac arrest, you can actually put cold fluids in there and not warm it and transfuse your patient really quickly to get them cold fast. And then you have fluid resuscitation for hypovolemia. What are my goals of therapy when using the rapid infuser? Obviously, number one, we're going to try to stop bleeding. And then we're going to actively rewarm patient to avoid hypothermia. We want to reverse coagopathies. We want to facilitate clot formation, and we want to restore blood carrying capacity to deliver oxygen to the vital organs fast. This is a fast therapy. It's to save our patient's life very quickly. The actual standard of care for massive transfusions, it's called a DCR. It's a damage control resuscitation. So this is something that you want to kind of consider when you're doing your therapy. Some physicians may handle it a little differently, but this is the recommendation. So it's the damage control resuscitation is, okay, rapid hemorrhage control, stop the bleeding, recognize that if there's coagopathies going on, control them. Permissive hypotension. So it's okay for these people to not necessarily have a huge blood pressure at this point, okay, because they may continue to bleed. If we don't control the bleeding and we're just got a vessel that's bursting or whatever, we could end up causing more problems. We want to keep our crystalloid use to a minimum, okay? And then there's usually a 1-to-1 ratio. So if you get an FFP, 1 FFP for every unit of blood that is transfused. And this is considered the standard of care for clinical practice. So how do I use this thing? What's my role? What's my role going to be with this use? You want to get consent. But you also need to remember this is blood. So are there any personal or cultural or religious objections to receiving blood? Pretty much everybody knows that Jehovah's Witnesses usually refuse blood. Okay, so those are a pretty easy one. But what else? Who else can actually refuse blood? You can't just assume that everybody wants blood. Okay, there are people that say, hey, I'm not a Jehovah's Witness, but I'm making this decision based on a personal choice. So just be aware, they could choose, and they're not Jehovah's Witness, to just not want blood. So you need to this is one of those procedures you have to get consent for, talk to a family member or whatever. It needs to be well established in the record if they don't want blood, okay? We also want to educate our family and our patient what is going on, what is this therapy for. We want to review their history because we need to see if there's any renal disease or any congestive heart failure, because that's going to end up being an issue when we put so much volume into a patient so quickly. We need to also look that the only thing that is actually transfused through this device is blood and the IV fluid. So we don't want to be running our platelets through there, because those are fragile. We don't want to smash those. So just the blood and the IV fluids through the rapid transfuser. You also want to remember that this is going to be a massive transfusion protocol. There's not going to be time to type and cross. But while they're typing and crossing, so remember to still draw those labs, send them down. But while they're typing and crossing, they're going to end up giving you O-negative blood. And you want to get your patient typed and crossed really quickly to get them the correct unit of blood as fast as possible. You need to also anticipate that they're going to be given FFP, platelets, and cryoprecipitate to help with clotting issues, because these people can tend to massively continue to bleed out because all their coags are being depleted as well. You want to assess their vital signs and their hemodynamics. It's great if they have a PA catheter. That would be wonderful. If they don't, through a central line to figure out what their hemodynamics are. And then you want to assess their lab values. Continue to look at those for trends. You want to look at what kind of an IV do they have. You need to make sure that this is an 18 gauge or larger. It cannot go in anything smaller, because remember, it's a hose and it's going to deliver. It needs to deliver through a big gauge, and you cannot use your PICC lines for this. This is not approved for PICC lines, okay? And then you want to go ahead and put warm blankets on your patient to prevent heat loss. It's sometimes something we forget. We get in a hurry, start treating our patient, and they're laying there exposed or just a sheet on. They're going to get cold fast. So get some blankets, designate somebody to wrap them up and put some blankets on them, keep them warm. So how am I going to use this thing? You're going to want to make sure that when you open up this box that you clamp everything. Clamp all the lines, clamp, 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 clamp. Then you're going to spike your fluid bags and you're going to hang them on the hooks in the machine. And the machine actually has step-by-step directions on it. You can see up there in the corner on the left-hand side near the one that there's like a little guide. That's going to actually help you as well. So just slow down, stop, look at it, and then there's actually another guide down there on the machine near where the filter is. That's going to actually help you with putting the device correctly through this little filter thing. You want to make sure that you squeeze the chambers only halfway full, because this way you can assess it, make sure that the rate, that it's actually dripping. There's nothing more frustrating than you use one of these things and somebody has squeezed that thing all the way up and you can't tell how much it's actually running fast. So you want to make sure you prime your tubing, get all the air out, troubleshoot any alarms once you turn it on, find out what's going on before you hook it to your patient. So once you're ready and everything's good, machine's good to go, you want to go ahead and attach this to your patient and open up your clamps and slowly open up your rolling clamp, because this is going to make your desired rate, okay? The machine's just not going to slow down all of a sudden miraculously. That roller clamp is your rate control on how fast this is going to run from that, 70 to 30,000 mLs an hour, okay? You're going to monitor your vital signs every 5 minutes, set that blood pressure cuff to cycle. You want to look at your core temperature, find out, are they going hypothermic? Okay, is there something wrong that your machine's not warming your blood going through it? Monitor the urine output, make sure their kidneys are perfused with good urinary output. And then you want to be looking for signs and symptoms of a transfusion reaction, because remember, we're doing a massive transfusion protocol, so they're giving you O negative. We haven't had time to type and cross. So you want to look to see if there's any transfusion reactions at all. Keep all your supplies, your transfused blood in the room until you are like 24 hours out from giving your blood. And then you're going to monitor your labs, your CBC, your electrolytes, and your ABGs as well. Potential complications that can happen from using your rapid infuser. Obviously, we can end up with some lung injuries and some fluid overload. So that's a key number one complication. You can also end up with some acute kidney injuries because of reperfusion, all right? And then you've got hypothermia that can develop. Some of the labs you really need to pay attention to is your potassium and your magnesium and your calcium. So you can end up with hyperkalemia, hypocalcemia, which can lead to acute pancreatitis, which can be very deadly for these patients. And you can have hypomagnesium, okay? You need to be looking for potential allergic reactions and air embolism. Remember, this is running at a high rate. It's a big tubing. You can accidentally deliver an air embolism to your patient. So it's very important to slow down, make sure things are clamped. There's also a retrospective study that was done because they were looking to see if some potential complications were related to the number of days that blood had been stored in the blood bank. On average, blood banks will hold blood up to 45 days, okay? And this study did reveal that there was no increase in mortality based on the number of days old that blood was as compared to non-trauma patients as well. So that's something to consider. So the length of days of blood does not necessarily matter for complications. How do you maintain your nursing competence when it comes to this? Well, again, this is going to be practice. You have to practice with this machine. Get your hands on it. If there's skills fairs, anything like that, if there's an opportunity, you need to look to learn. This is a hands-on skill. But then you also need to critically think through the scenarios. You don't want to just know how to work the machine. You need to see how your patient responds to the blood. Do they have the proper IV access? How did they respond to the calcium level? What's their calcium level like? What is their potassium level like? Because all this therapy will affect all of that. So massive transfusion protocols are considered high impact and low frequency and require the facilities to have protocols in place. And in Florida, we have the massive transfusion protocol. So I would encourage you to look that up and see what that says periodically to make sure you are aware in case your patient has that ordered for them at some point. And then simulations, being involved in simulations will actually help to maintain your skills. The guidelines for massive transfusion protocols are provided by the American College of Surgeons Trauma Quality Improvement Program, and they're always looking at it and considering improvements. Okay, you need to review the guideline elements and performance indicators that they recommend. In conclusion, high-risk, low-volume therapies, basically these are therapies that occur infrequently or that you as a nurse perform infrequently. Okay, they're going to be things that you don't do on a consistent basis. So for example, you may, if you're working in our facility with 350, 400 beds, a central line is not considered a high risk for you, low volume. You're working with them every day that you're at work. But if you took those and you put them in a 50-bed rural hospital that hardly ever uses them, that would be considered a high risk, low volume. So there's not one indicator for every hospital as being a high risk, low volume, okay? For our facility, we've identified the EVD because you don't do these every single week. Sometimes we've had high volumes, but a lot of you don't do these every single week. The biz monitor, same thing. We're not paralyzing every patient. We're not using them all the time. With our core tracks, there's a handful of us that just learned this and became super users last year. So we're just gaining our confidence with this. And some of us are more proficient than others. So it doesn't matter how proficient you are, we always need to reassess our competence with the core track. And then the rapid infuser, again, a lot of y'all have seen, that's a very infrequent thing. And when it happens, a lot of people are interested. All of us run over there to take a look at it. But it is something that is considered a high risk, low volume for our facility. You need to realize that there's no standardized method of measuring your competence. We have some checklists through EBSCO to help our educators come through. They provide skills fairs. If you ask them, they may let you demonstrate a little bit more with something. And then you've got other, preceptors in the unit that can help you if they have it going in their patient's room and teach you a little bit more about it. The synergy model of the American Association of Critical Care Nurses, this is actually their model for synergy says, okay, let's match a patient up with the nursing characteristics that will provide the best patient care outcomes. So our patients with these therapies, we need to have nurses that know how to take care of them. And if they're low volume, how do we get there? So we're going to need, as you have a patient that arises with this, that patient's need is going to help drive your nursing competency. So hopefully what you're doing is you're seeking out information. How do I become more competent in this use? What do I do? What are my resources available for this? How can I figure out how to safely use this for my patient? And you also need to remember too that the Joint Commission does not necessarily assess competence by simple things that you learned in school, like do you know how to assess breath sounds? They're not going to look at that. They may say, okay, can you as a nurse in a neuro-intensive care unit do an advanced neuro assessment? Okay, so Joint Commission is going to come in and they're going to say, all right, we're assessing competence based on a combination of indicators to evaluate your employee performance for a skill. All right, so that's kind of what they're looking for. We all have professional accountability when it comes to containing costs for our patients. This is a very serious thing when taking care of patients. Cost is a big deal. So we want to make sure that we gather only the needed supplies that we need. You want to think before you enter the patient's room. Are they in a contact room? Because once you bring that supply into the contact room, you really shouldn't be bringing it out to be used on anybody else, okay? So don't open up any packages unless they're needed. If your patient, let's go back to the contact room. If your patient's in a contact room, get a cart, place some things outside the room so that you can easily go get it and then bring it into the room for use and open it instead of bringing everything into the room and now you have to dump it all, okay? Let's slow down a bit. Just slow down and grab only the necessary things, like I said, and try not to be fast with opening things that we're going to end up having to throw away. Return your unused supplies and make sure you scan things, okay? Another thing too sometimes is to look at the costs of things. So in communication with our supplies director, Annette, Mrs. Arnett, she communicated to me how much certain things cost. So our EVD Codman, this is only for facility, okay? A much higher rate gets charged to the patient. So each Codman kit that our physician uses has the drill in it. That's $350. The EVD drainage system that you get primed and ready to go to attach to his catheter is $300. For the Biz head sensor, that's $30 a pop, okay? The CoreTrack small bore feeding tube that you use is $60 each. And then the rapid infuser tubing is $60. So remember, this is hospital cost. So what costs the hospital is going to end up costing the patient much, much higher. At North Florida Regional Medical Center, the accreditation and certification is given to this facility through the Joint Commission and through the Det Norske Veritas GL, or DNV-GL. Both have the ability to accredit hospitals and to give certifications to hospitals. We currently have a certification. We're a comprehensive stroke center through the Det Norske Veritas GL, and we are accredited as a hospital and recognized as a top performer through the Joint Commission. And here you can see for our stroke certification, it actually has a mandatory 8-hour stroke care specific education annually requirements for these staff members. So if you have anybody on an acute care, stroke team, an ICU nurse manager or educator, any nurses in a neuro-dedicated ICU, a mixed population ICU RNs, and interventionalist nurses, all of these people have to maintain 8 hours of stroke education per year. And they can do it online, they can do it through grand rounds, regional and national meetings, or educational courses. But that has to be done. And it has to be specific. Like you can't count 8 hours as just anything. Say you take a course in GI, in protonics or something. This has to be specifically stroke related education, separate from the others. And then the Joint Commission there, you can see they have national patient safety goals that you can go to their website and look at. They've already, 2019 is already up there. We should be familiar with what they are. And they also, when they come around, they survey your facility. They look at a number of functions of the hospital. These include the infection control, medication administration, how do we take care of the patients, do we maintain the rights of the patients, what is the environment that the patients are in, what is human resources like, what's our leadership standards, and life safety, the medical staff, which is the doctors, they look at nursing, they look at performance improvements, and they'll look at all the medical records, educational records, employee potential, anything that affects patient care, they can look at any given time. Personal career development is important. So if you are currently an RN, you have the option to go back and do a program that's RN to BSN, RN to MSN, or RN to DNP. If you currently have your bachelor's degree, you can look at programs that are BSN to MSN or BSN to DNP. There are lots of online options that are available to further your academic career. A lot of employers will also reimburse you when you do this. So look at your human resources and see. I know at North Florida we do reimburse for these things once you complete your degree or during the process of completing your degree. So let me tell you a little bit about myself and how I've developed my professional career over the years. I actually received my LPN from Washington Holmes Technical Vocational Center in 1995. I received my RN from Santa Fe College in 2008, and I got my certification, my CCRN, in October 2018. And I will be getting my bachelor's from Jacksonville University April 27th, 2019. Very excited about that. I also anticipate starting my BSN to MSN in clinical education after applying and being accepted at Jacksonville University either the end of this year or the beginning of next year. I'm very excited about that. Made my decision to just go education because I love education. And Jacksonville is my university of choice. This school has been amazing for me. I feel like I have learned a lot. Actually, when I hear other nurses talking about their programs that they're in, when they say, oh, it's just busy work, or oh, I'm not learning anything, I actually feel bad for them because I feel like I have gotten an excellent education at Jacksonville University. But I also believe you get out of it what you put into it. And I have really enjoyed every bit of opportunity that I have had through my assignments at Jacksonville to advance myself and impact patient care and look at evidence-based practice. So they're an excellent program. They offer 8-week courses, and I am so excited to apply and start my academic advancement at the end of the year or beginning of next year. And the next thing I'm going to be doing, hopefully this year, I am going to get my certification and get my SCRN for stroke certification this year. So that's about me. Thank you very much for going through my presentation. I appreciate it. And this completes my presentation for high risk, low volume therapies and education for ICU nurses. Thank you once again.